Dr. Barbara Šikšniūtė, and she will present us some different modalities: histoscanning, yes, and transperineal biopsy. Am I right?
Yes. Yep.
Okay. So, Barbara, it's your time. Let's show us what we are doing with these things in biopsy in prostate.
Yeah. So I will start my presentation about the histoscanning transperineal prostate biopsies, and I will present some cases. What is histoscanning? So it is computer-aided interpretation of prostate in 3D ultrasound scans. It utilizes the tissue characterization algorithms. It visualizes the position and volume of undifferentiated tissue suspicious of being prostate cancer. So here we see some images. Tissue marked in red is statistically comparable to suspicious undifferentiated tissue. And so how does it work? It uses several mathematical and statistical algorithms to differentiate the prostate cancer signatures from other data. Algorithms were trained and validated on a 3 millimeter hole mounted section. So it cuts the prostate into the images of 3 millimeters. How do we use the prostate histoscanning? So first of all, we need an ultrasound. We need a 3D ultrasound probe with the rotator cuff to make the prostate scanning possible. Prostate borders are defined on the computer and 3D image is obtained. So here is a picture of the rotator ring that allows the scanning of the whole prostate, which later translates the images to 3D image. It is very important using a histoscan to actually prepare the patient and the procedure. So before the scan, patient should be prepared. Laxatives or enema should be given. We should also ask the patients to empty the bladder to limit the pressure of the prostate. We also have to use a good acoustic gel with minimal bubbles, with good viscosity and good acoustic connectivity. Use a good condom for the close contact with the transducer, and avoid the air in the gel, condom and rectum. Also, we should explain well the procedure for the patient to calm him down so he doesn't move during the procedure. And all of this is done to avoid the artifacts. So we jump into the clinical cases, and the clinical case number 1 is of a patient of 72 years. In 2013, he had a PSA of 4.2 nanograms per milliliter. Patient received 2 transrectal biopsies. They were both negative. PSA continued to increase up to 7.9 nanograms per milliliter in 2014. Prostate volume was of 39 milliliters. So histoscanning was performed with the transrectal targeted biopsy. Here we see an image of the prostate with suspected lesions. We see a grid which shows that in a place of B3 and C3 we have a suspected lesions with connectivity of more than 0.5. And targeted prostate biopsy was done. Here you can see on the picture the needle position. It is shown the right position, that's why the biopsy should be easier to perform. So what did we get? We got the histology result of adenocarcinoma Gleason 7, 4+3 in less than 5%. The treatment was chosen of active surveillance. So clinical case number 2, a patient of 44 years, with the positive family anamnesis for prostate cancer. His PSA was 3.6 nanograms per milliliter. On digital rectal examination, there were no abnormalities found. Prostate volume of 36 milliliters. Again, the histoscanning was performed. We see the image. So the lesion was bigger than 0.5 centimeters. Theoretically, if it's more than 0.5 centimeters, the probability to find the malignancy should go up to 90%. So here is the suspected lesion. What has been done? So transperineal prostate biopsy was performed. 2 targeted biopsies were done on the left apex and the right apex, and also 12 systemic prostate biopsies were taken. So histology came back positive only in targeted prostate biopsies, which found adenocarcinoma Gleason 6, 3+3, in 1 left and 2 right cores. So, what is the future? We will start talking about this. In 2012, when this whole thing started, the clinical study data showed the sensitivity of the prostate histoscanning at 90 and the specificity of 70, even in small lesions. Later, the histoscanning has promised that if the lesion is more than 0.5 cc's, 75% of all patients have or should have a positive biopsy for prostate cancer. However, with the time going forward, in 2017, there was a comparative study done that supported histoscanning, but only when MRI imaging was not possible or not available. So after, again, I think it was 2019, the literature review on histoscanning by Tania concluded that the future of histoscanning remains unclear. So you can see that with the time, there's less and less evidence of histoscanning to be productive as it was promised in 2012. So I will continue with the second part of my presentation, which is transperineal prostate biopsies in National Cancer Institute. So about all the prostate biopsies, first of all, transrectal prostate biopsy was first performed in 1985. Transperineal prostate biopsy was done in 2013, and it continues to grow until now. Cognitive mapping in 2016, MRI fusion with the Biojet in 2018, and now this year we're proud to say that we have started the MRI targeted biopsy in bore. So about multiparametric MRI that we have spoken a little bit today, pre-biopsy MRI and MRI targeting lead to improved detection of high-grade cancer. The intention of pre-biopsy MRI is to reduce the detection of indolent cancers, and it balances the detection of high-grade disease and avoid low-grade cancer. So this was the conclusion of Tania in Genitourinary Cancer Symposium of American Association of Clinical Oncology. So why should we choose transperineal versus transrectal prostate biopsy? First of all, because of the reduced risk of infection, better access to anterior targets, it incorporates a high volume prostate. It is identical orientation to focal therapies. It is connected through the perineum. And technique is equally possible under local anesthesia. Also, very important, slightly higher detection of the prostate cancer. Here we see a diagram of transperineal prostate biopsy. So here we see the brachytherapy grid, ultrasound probe, and the picture of the prostate itself. And this is this is how it's performed in real life, a picture from the procedure. So patient is in lithotomic position, and in this case patient is under general anesthesia. Here the brachytherapy grid is applied or mounted. And we can see a better picture to see how the brachytherapy grid is, it's close by the prostate biopsy. So, clinical case for transperineal prostate biopsy, a patient of 69 years with the PSA level growing from 5.4 to 6.9 in 2019. 2 transrectal prostate biopsies were done. Both of them were negative in 2017 and 2018. On MRI, we saw a suspicious lesion about 5 millimeters, peripheral zone in right apex, and the prostate volume was 60 milliliters. Here we see a modified Barzell zones that are used for transperineal biopsies. And a live picture from the operating room with the brachytherapy grid and where the prostate biopsy is supposed to be taken from. So again, we mount the ultrasound probe, we mount the brachytherapy grid, we take the biopsy, and what came back for histology was adenocarcinoma 7, Gleason 7 3+4, and patient underwent a radical prostatectomy. So the big question here, whether to choose a computer or human brain, fusion or cognitive. So comparison of targeted versus systematic prostate biopsies in men who are biopsy-naive patients showed no major differences in cognitive versus fusion biopsies. Cancer detection rate was almost at the same level. So for cognitive prostate biopsies, we had 33%, and for fusion, 38%. Again, randomized control studies were done. Higher detection of smaller lesions using fusion technique was found, and detection of clinically significant prostate cancer was slightly higher in fusion biopsy, which was 68%, versus cognitive biopsy of 64%. So, potential benefits for the fusion biopsy is we need less experience, so younger doctors can probably perform it better. No targeted biopsy learning curve is needed, but mainly learning curve of software use. it may increase also the correct distribution of systematic cores. It may help in detecting and characterizing smaller lesions, and it may benefit the subsequent treatment, radiotherapy, prostatectomy, or focal therapy. So what is the benefit of cognitive prostate biopsies? It is quick, it is cheap, and it's easy. We don't need any contouring, image overlapping, we don't need the software, machine-related expenses, and no software learning. So in conclusion, multiparametric MRI is the key to improve the diagnosis, and it helps to improve the treatment. Which of the two, fusion or cognitive, is the best way to translate this information is not yet clear. No advantages of one technique over other was found. Fusion software may show advantages in beginning of the learning curve, especially in cases of smaller lesions, and to guide a subsequent prostate treatment or monitoring. So it is not what is, it's not, it is, both of them are really good. However, we need the experience with the software, with the prostate biopsies. So I think both of them are really good. Let's do what we do the best. And thank you for your attention.
Thank you, Barbara. Thank you, Barbara, for the presentation. So I again ask everybody who is listening to our conference to ask some questions to every presenter, every lecturer, but still I don't see them. Actually, I'd like to ask you, Barbara, you showed that, yes, it's quite, looks like it's quite easy to do the cognitive biopsy, but still you have to imagine, because usually prostate cancer is not seen on ultrasound, as you saw. Even histoscanning couldn't show clearly the boundaries of the prostate cancer. So the only modality today that could really show the cancer is MRI, and I couldn't agree with you that it's very easy to find these. Of course, if the cancer is in the whole prostate, then we don't need any targeted biopsies at all. We can take the biopsy from any site and we will find the cancer. But if the cancer is very small, actually it's not so easy to find it with a cognitive guidance. Even if the fusion guidance, it's not so easy if it's really small cancer. So I think that even cognitive biopsy, I did a lot of cognitive biopsies, and sometimes even while thinking as a radiologist in 3D, it seems quite difficult to find the place where we can imagine there is the cancer. What's your ideas about that?
I couldn't agree more. I couldn't agree more. I guess for the younger colleagues and from me myself, I would prefer the software a little bit more. However, with the experience, when you have the experience, it gets easier and easier to take the prostate biopsies. So therefore, it is difficult, I think, to comment on it, because the scientific papers were obviously written. You need to make a really clear data collection. Or you can do it by the age, you can do it by the center. Not all the centers have the possibility to do the MRI fusion. So so it really depends on who's doing it, how it's done, and where it's done, I think.
Yeah, and one more thing, I think cognitive biopsy could be done not only in transperineal way, because as you showed, you need some grids, brachytherapy, stepper, and so on to do that. It also costs money, and if the center doesn't do the the brachytherapy, so maybe this center won't have that stuff in this center. So I think cognitive biopsy could be done in any way, transperineally, with guidance, without the guidance, freehand. Am I right?
I'm sorry, I didn't really understand the question. Could you repeat it?
I am speaking about cognitive biopsy.
Yeah. Transperineal.
Yeah. No. Why transperineal? You can do the biopsy in freehand or with some guidance, just to find transrectally the tumor, which you imagine that it's there according to MRI images, and you can do it almost freehand, like you do in transrectal ultrasound guided biopsies, blinded biopsies, these systematic biopsies. So
I'm sorry. I guess it's evolving a lot. Before we used to have the answer from radiologists that it would be in the apex. Now we have a mapping of the prostate, right? Usually if the MRI was done. Then the fusion possibilities. So every year it's evolving, and radiologists are great help for us.
Okay. So actually the possibilities are big, and just we need to find the best possibility for each center. I think even without any equipment we can do the biopsy. Just we need to think a little bit and to do the right ways, the right things. But MRI is number one, what we need to have before the starting doing biopsies. Of course, we can start with, if we don't have MRI, then we can do the systematic biopsy and to find or not to find the cancer. Yeah. But with MRI, it's better.
Absolutely.
Thank you very much.
Thank you.